morning, good afternoon, and good evening, and welcome everyone to another session of our IFA Global Café. My name is Katrina Brazanis. I'm the Director of Policy, Advocacy, and Innovation here at the IFA. So the increasing populations of older people around the world underscores the importance of addressing health issues that are specific to older adults. So older people face increased risk and prevalence of disease and multimorbidity, oftentimes having many conditions to manage at once. And many of these factors may contribute to the likelihood of something called prescribing cascades, which occur when the side effects of a medication are misinterpreted as a new medical condition, leading to the prescription of additional medications to treat these side effects. And so this is particularly poignant and prevalent amongst older adults. So to speak more on this topic, we have Dr. Paula Rochon. So Dr. Paula Rochon is the founding director of Women's Age Lab at Women's College Hospital and professor in the Department of Medicine and Institute of Health Policy, Management, and Evaluation, and RTO/ERO chair in geriatric medicine at the University of Toronto. Her career has focused on promoting the health and well-being of older adults, particularly women, and finding new ways to improve their lives. Dr. Rochon has published 300 papers in peer-reviewed journals and is the chair of the Canadian Institutes of Health Research Institute of Aging Advisory Board, deputy editor of the Journal of the American Geriatric Society, and was awarded the Eugenie Stewart Award for Best Thesis Supervisor from the University of Toronto. She's also founded Women's Age Lab, which is the first and only research center of its kind to focus on improving the health and well-being of older women. So Dr. Rochon, welcome to the Global Cafe, and thank you so much for joining us.
Well, thank you. It's a pleasure to be here this morning.
So we always kind of kick off, obviously today's session is centered around prescribing cascades, which we hope that you can kind of go into detail and share a little bit more about some of the definitions of what exactly that means. But we always want to kind of start at the beginning, and I'm wondering if you can tell us a little bit about yourself and your journey.
So I'm a geriatrician, as you've just said, and a health services researcher. But geriatrics is something that I got interested in, I would say, sort of late in my medical career. In my particular circumstance, when I was, finishing up medicine and doing my residency, I was thinking more about my grandparents. And at that time, my grandfather was 102 and he lived to just almost 103. And my grandmother was well into her 90s. And I started being very interested in aging. How do you age well? And, I realized that, this is something that's important to all of us, but not something that, everyone is able to do, at least in the way my grandfather did. And then over and through my training, I got more and more interested in thinking about older adults and aging well, some of the issues that we needed to think about, and particularly got interested in women and aging, because as I went through my training and got into geriatric medicine, I increasingly saw older adults, but particularly women, and started to think about some of the issues that were important to them. And then I guess, as you can imagine, as a clinician caring for many different people, medications was something that came up over and over and over again, and thinking about, how best to prescribe them and how can we make sure that people get the benefit and reduce any potential for adverse events. So that's how I increasingly got interested, I would say, into some of the things that we'll talk about today.
Yeah, thank you so much for sharing that, and I think we'll hopefully dive in a little bit into the impact on women specifically, which I know, of course, is a big focus of yours. So can you tell us a little bit about what is a prescribing cascade, and what exactly does that mean, and what are some examples of prescribing cascades?
Yeah, so this is a framework that myself and a colleague, Jerry Gurwitz, wrote about first quite a number of years ago. It's sort of one of the things you write about, and it's one that's become, I think, increasingly important over time. So basically, it happens when as a clinician, a drug is prescribed. Then sometime later, a new medical condition develops. It's really an adverse drug event, but it's misinterpreted as a new medical condition. And then another drug is prescribed to treat what's presumed to be that new medical condition. So as you can imagine, it just starts this whole cascade of events going forward. So as an example, I mean, some of these things are fairly commonplace and very important for people to think about. So for example, people can take medications like NSAIDs, the kinds of things that you would take for, maybe arthritis pain, can be very helpful medications. But sometimes those medications can cause an elevation of your blood pressure over time. And if a person or a clinician, sees somebody and their blood pressure is elevated, they may not be thinking, was there a medication that could have contributed to that? And instead, they get now started on another medication to treat what's presumed to be a blood pressure problem. And this is important because, if you don't start to think about, could this be drug related, you're now on another medication, which could lead to another problem and another medication. And maybe you don't need that at all. Maybe all you really needed to do is to go back and say, okay, was that first medication needed? Did you really need something for your blood pressure? Maybe you did. But maybe you didn't actually need that. Maybe it was the result of, for example, in this case, the NSAID that was prescribed. And why was the NSAID prescribed? Well, often it's prescribed if, people have some sort of arthritis pain, but maybe there was another medication that could have been used, or maybe it could have been done at a lower dose and you could have prevented these problems from occurring. So these are sort of situations that, as you can imagine, could happen in a lot of different ways. And when we first described this idea, we talked about 3 different prescribing cascades. Those were the examples that we had. And what's interesting is over time, and with people thinking about it, there's many, many more prescribing cascades. So when we looked at the literature recently, there's about 170 different prescribing cascades that have been written about in the literature. But there's probably way more that are out there that, people might have sort of be able to relate to in their own experiences, or if you think about it. So it's something that started off with sort of this idea, this sort of framework of a potential issue. And it's one that I think has really caught on. And so people hopefully are now thinking about that when they're prescribing their medications.
Mm-hmm. And do we have any sort of insight on the burden of this happening to older adults? How do we understand kind of how many prescribing cascades are out there? I think the 170 that you said seems like such a huge number, but in clinical practice, how do you also understand how many people may be kind of misprescribed because of this phenomenon?
I don't know if we can say how many people are misprescribed, but I think it's something where we should always think about it when you're about to prescribe a new medication. Or, I think it's really important when, often people are on medications for very long periods of time, when your medications are reviewed. Because sometimes, these are things, there's, as I say, there's a list of prescribing cascades and different prescribing cascades that have been published and talked about in the literature. But it's important to think about it in an individual circumstance when you're looking at their medications, to think if this pattern could be contributing to some of the medications that they're on and that, maybe could be revised. So I'm not really sure to sort of give a number about that, but I think it's something that, you really ought to think about whenever you have your medications reviewed.
And I'm curious kind of how this phenomenon also relates to multimorbidity in older adults. Because I think, obviously many older adults have multiple conditions that they're being treated for or potentially have prescriptions for. And so wondering if you can speak to, what is the connection between multimorbidity and having kind of at risk, I guess, for prescribing cascades.
Well, I think there's definitely a connection. I mean, as people get older, you tend to develop what we call chronic medical conditions. And often these medical conditions are treated in a variety of different ways, but one of them includes medications. And medications are very, very helpful, and they can be, you know, essential in therapy. So that's important. But over time, people may have more than one medical condition and may require different different therapies to manage those conditions. So it does really relate to this idea of multimorbidity. And so that's why, I guess, in part, this is something that we've focused on, particularly in geriatric medicine, as I say, because with age, people tend to develop more medical conditions, but may also be particularly important also for women, because women tend to have more chronic medical conditions than men. So these things are, I would say, kind of interrelated.
Mm-hmm. Mm-hmm. Um, so how, you know, maybe we'll go first to kind of the women point, which is, can you speak to kind of what the experience is for women, in particular when it comes to prescribing cascades, and what sort of, is there any kind of outsized burden in terms of either, polypharmacy, or you mentioned kind of the increased prevalence of multimorbidity or NCDs?
Well, I think it's something to think about in everybody and really of all ages. It's just something that you want to think about that concept. But it could be particularly relevant for women because, as I say, women tend to have more chronic conditions that may require drug therapies. And people say that on overall, women tend to be on more medications than men and may be more predisposed to developing adverse events from medications. There may be some differences there. So while it's important for everybody, I think it may be particularly important to think about for women. So just something to keep in mind.
Mm-hmm. And can you share, is there any kind of clinical experiences from your own kind of practice that you can share, or any kind of maybe more specific examples, and how maybe you've kind of rethought your approach to care upon learning more about this phenomenon?
Yes. So I guess there's a couple of pieces there. I'm sort of thinking back to some of the different cases that we've seen over the years that maybe made me think about this more. And sometimes these are patterns of things that you don't really recognize unless you really stop and think about it. So I remember once in my clinical practice seeing a woman who had developed gout, which is, can be very, very painful for people. And I was being asked as a consultant to go in and to talk about how this condition could be managed. And, one of the managements is a medical therapy to give the person a medication, which is fine. And so we did that, and, she improved, which is good. But then, many months later, I was asked to see her again, and she again had this experience of gout, which is very, very painful. And we started looking, as a geriatrician, one of the things you do is you look at medications as you're reviewing all of the pieces as part of a consultation, and started to notice the pattern that when this woman would develop a little bit of swelling in her ankles. It wasn't really bad, but she had a little bit of swelling in her ankles. And she would get put on a diuretic therapy to manage this swelling. And it turned out that the diuretic therapy sort of triggered a little bit of volume depletion and elevated her uric acid level, which was something that actually was triggering her to develop this gout. And when we saw that combination of things, we thought, okay, when she develops this bit of edema, is there another way that it could be treated? And in her case, elevating her legs was what she needed. She didn't really require a medication. And by doing that, we were able to stop her having these painful episodes of the gout. And so it was thinking about how these things might be connected that we started to see a pattern, perhaps of things that you might not otherwise recognize. And by doing that, clearly, you avoid this circumstance that can be very painful for people, but you also take away, the need for a medication because, there was another way that it could be treated in this case. So it's really important to kind of look for these patterns. And one of the things that I've started to notice over time that everyone can do, but physicians can do this, but patients can do this too, is it's really important to keep a list of the medications that you're on and to document when they were started and why they were started and who started them. Because you can imagine for some medical conditions, you can be on therapies for a long period of time. And sometimes everyone forgets, when did they actually get started and why were they actually started? And by knowing that, you can start to see sequence of events. Oh, this drug was started first, and then later this one was started. And why was it started? And that can help you unearth sort of examples of some of these potential prescribing cascades.
Mhm. Mhm.
Another one that I mentioned earlier on is the use of sort of non-steroidal anti-inflammatory drugs, which again can be very helpful if you have pain, for example, or if you have some arthritis discomfort. And so they can be very good therapies. But one of the things that we've noticed is it can also lead to an increase in your blood pressure. So if you can imagine months ago, you've developed some arthritis pain, the decision was to put you on that medication. Months later, you happen to be in your doctor's office, they check your blood pressure and it's a little bit more elevated. And then they're starting to wonder, should you be on a medication for your blood pressure? But maybe if you go back and you say, well, was there something else that could have been done for that arthritis? Was there another medication that could have been used that didn't have this side effect profile? Or was there something more from an exercise perspective that might have been helpful with the discomfort? Maybe you didn't need a medication at all. Or if you needed a medication, could there have been a lower dose? And then maybe this blood pressure problem wouldn't have developed at all. Or maybe that's what you did need, and now we just need to treat the blood pressure. But it makes you think, and it allows you the chance to go back and make any kinds of changes that might be helpful.
Mhm. Yeah, thanks so much for that response. We do have a few questions in the chat already, so I'm gonna go to some of these questions here. So we have a question from Shmuel, who is a weekly contributor at our Global Cafe, and they're asking, what should be the role of governments or authorities in preventing prescribing cascades among older people? Is there any kind of authorities that need to come in order to prevent this problem?
That's a great question because I think it's one thing for us to talk about it, but I do think that that is important for people to think about this as well and physicians to think about it. But there is an opportunity, for example, to think about this in a couple of different ways. So one is, medication review process. So those are often things that happen. For example, in my country, which is Canada, those are something that a pharmacist can do to review people's medications, and you would ask them to think about, could there be prescribing cascades going on? And so that's sort of one thing that could be done. Another is that we could look at it when you're thinking about medications that are being prescribed. So it is possible that when you know about these different prescribing cascades, they could be built into, for example, electronic systems that you have to help monitor. So when people are doing prescribing, you might get some alerts, for example, that say, pay attention here, or at least consider the fact that this could be a prescribing cascade. So I think there's ways that you could take this information and think about how to put it in practice.
Mhm.
Some of the work that we're doing right now is looking at how these occur, not just at an individual level, but also at the level of many people. So, for example, at a province level, so looking at large numbers of older people. And that kind of work can tell you, maybe where some of the more common ones are and places where a different kind of authorities might want to bring more attention to it. So really, really good question, because it's important at the individual level, but there's another number of other ways that we can potentially think about addressing this problem.
Mhm. Yes, I mean, maybe just a quick question on that before I kind of go back to our chat here. But how have you gone about also making sure that other healthcare providers are aware and kind of increasing awareness amongst healthcare providers?
So part of it is like raising awareness. So when we talked about this, you know, a number of years ago, it was sort of like one or two prescribing cascades that we talked about, and it wasn't something that was sort of widely out there. But by publishing about it and talking about it in a variety of different ways, as I say, we've really raised awareness about this. And now I think there's people that have written about prescribing cascades in countries all around the world. So, it's people are not just seeing it in Canada, they're seeing it all around in Europe and in Australia and South America. Like, people are writing about this in all different places. So people are thinking about it in different contexts. It's also been picked up, in the public domain. So there's been articles written about it in the New York Times. People talking about stories, and stories are so important because they help people think about things, because there's maybe not only one way that these cascades may occur, but ways that we've never really thought about before. But people are thinking about sort of the sequences of events. And there's a book that I really like called Elderhood, written by Louise Aronson, who's a geriatrician. And she has a whole chapter where she talks about prescribing cascades and how they impact people's lives. So I think, there's ways of sort of that message kind of coming out and people starting to think about it. I think that's really important to raise awareness.
Yeah, absolutely. And that's great to hear that it's also kind of made its way into the public domain. It's not just in peer-reviewed literature. It's also kind of making its way into the media and people are sharing more of their stories. Okay, I'm gonna go to a question, Catherine, from Catherine Klein. Do you want to unmute and pose your question, Catherine?
Sure, because it's relevant. It was another story, and this was my older mother-in-law who indeed had issues related to multiple medications. And the issue, particularly with older women, and we had a neighbor who we paid to make sure she took her medication, but it became the responsibility of her son, my husband, to do the kind of research, Google search of the different medications, because when she became disoriented, they thought, oh, well, that's just it. She's old, can't do anything. And it turned out, in fact, it was a reaction to one of the medications. And often, and then I'll stop, often he had to stop them because they're different doctors prescribing different medications for different types of concerns, and they don't talk to each other. So it's fine to have a geriatrician, but in a normal household, who is supposed to be responsible other than perhaps the adult child?
Yeah, well, I'm sorry to hear about that experience, but I think you've raised a really important issue. A lot of people, as we say, with people when they get older, they do have, multiple medical conditions, and medications can be so important and life-saving, but we have to make sure that people are on the right medications. And it is in part about remembering, like, when a medication was started, why it was started, and then sort of monitoring these things going forward. And one of the potential things that we're looking at that, can be related to these prescribing cascades is when you have different people doing the prescribing and people don't really know why this medication was started or even when it was started, and then why this one was subsequently done. And sometimes it's really, that's why I think it's important to record that kind of information. So it may well be and should be in your doctor's files as well. But sometimes, as I say, these things have happened a long time ago, and maybe you have a new physician or somebody else is there. it's just really important to document this kind of information and be aware yourself as well of this so that you can also bring it up with your prescriber and discuss some of these issues with them so that you ensure that people are on the right combination of medications.
But
So
who should, sorry to interrupt, who should
Hmm.
do that? Older women, often there isn't someone who necessarily has that information or has the ability to take it down. So
Yeah,
is it the response? There's no one like you accompanying many older people when they encounter these issues. So that's, I think, goes back to Shmuel's question. I mean, is there any framework? Is there any way to think of how to help people who often don't have a resource like what you're talking about? They don't even remember what medication they take. So if they're lucky, they have someone who at least sets out what they should be taking when, but they have no ability, many of these people, to follow up what you're talking about. So I'm just asking that question, then whose responsibility is it?
yeah, you've asked a really tough question because, in some regards, or, the responsibility is the prescriber, which is often a primary care prescriber who would have this kind of information. And you would want for a person who's on multiple medications to be able to have regular medication reviews happening that should involve, it could be the pharmacist, it could be family members. Also, they're asking, key questions. But I do think it is also important for family members or the individual to keep track where possible of these things. But as you say, I fully realize that that's not always feasible or possible. And I don't know that there is a simple solution there, but I do think it goes back to, having these reviews of medications done. One of the things I found really helpful in clinical practice was that sometimes you just didn't really know what people were on. And even if you have your lists of what you think the person's on, it may be different than what's actually happening in reality. And I would always ask people, we had this brown paper bag kind of approach where put everything that's being taken or everything that you're taking in a brown paper bag and you bring it in so we can start, to go through these medications. Because remember, people take medications that are prescribed, but they also take things that maybe they don't consider them medications, but they are the things that they're taking over the counter. And so it's really important to have a sense of what all of this is. And so as part of that medication review to sort of get at some of the issues that you're talking about, I think it's really important to bring all of these things in so you have a sense of what it is, and then actually sort of leave that individual with exactly what they ought to be taking. And then people use different kinds of organizers that can be helpful. Sometimes those pill boxes or different things that work for individuals to help keep them organized with their medications. But you've raised a very important practical point, that it can be very difficult in practice to know exactly what's happening in the home and to try to manage that. But that is maybe one of the ways to start figuring out what's going on and to provide some guidance.
Mhm. Thank you, Dr. Rochon, for your response. And then we have a related question from Ralph, I think. Ralph, did you want to add to the discussion with your question? Or I can voice it as well if you'd like. Okay. I see Ralph, but I'll voice your question. So they're asking, is there kind of a danger of multiple medical treatment resulting in a cascade, particularly when it's a new patient? And also, I think also we may have answered your question about kind of an audit by doctors and pharmacists. But I think that there's maybe nuance there when you have a new patient and any kind of tips for onboarding a new patient?
Well, I think when you're starting a new patient, it's important to become familiar with their medications and to ask, basic questions. Like you want to have a list of the medications. And it is helpful, as I say, to know when the medications were started and who started them and why, so that they can be reviewed. But then it's also important, as a patient too, that you can ask questions about the medications, especially when a new medication is being started. The questions I like to ask are, could an existing drug therapy be causing a new medical condition, before you start another drug therapy? And could a lower dose be used as an alternative? And then also asking the question of, before medications are being started, is this drug needed at all? So there's pieces that you can do when you're reviewing the medications, but there's also things that you can ask specifically when a new issue is coming forward and you're being considered for a new prescription, to make sure that you avoid, wherever possible, things like prescribing cascades.
Thank you. We also have a question from Francis. Francis, did you want to unmute and pose your question?
Sure. Excuse me, I'll ask it. This is also driven by a family experience of a elderly cousin who, when I finally looked at his list of medications, was taking at least 27 different things. And among those were at least 3 or 4 what I would call psychotropic drugs that were, I think, given to him for anxiety, but he was still on all of them. And when I talked to him about that, his doctor at the time, he has a new doctor now, but their attitude seemed to be, well, doesn't seem to be hurting you. It seems to be working still, so we might as well keep you on these things. And I was particularly wondering if you could say anything about people that end up on these psychotropics for a long time and how those might be interacting with other things.
Yeah, sorry to hear that. I mean, 27 medications is a lot of medications. You can even imagine, how on earth do you keep that organized?
Exactly.
So you really have to, this is the time where you do want to make sure you sit down and review the medications, and also think about, kind of what are the pieces that you're treating. What are the goals of care? What are the things that are really the areas that you need to focus on? We've created sort of an algorithm that talks about some of the questions you might ask as you're reviewing medications. We use the acronym DRUGS to help people think about how you review these medications. Like, one of the first ones is discussing what are the goals of care, like what are you trying to achieve? Some medications, like psychotropic medications, can be invaluable for people, but if they're not needed, then that's a whole nother scenario. So I think, when you're describing 27 medications, I mean, that's clearly polypharmacy. Often polypharmacy, you're talking about 5 or more medications. Not that the number matters. It's just, polypharmacy is just sort of thinking about the multitude. And some people, they need 5 medications, and some people, they need 10 medications, but in some people, they don't. And so I think in a case like this is one where you really do want to sit down and look at all of those medications and see what are the ones that are actually needed in this particular case. So yeah, that's a really difficult situation.
Thank you. Fortunately, he has a new doctor who is doing that, but it was very worrying for a while.
I can imagine.
Thank you, Francis, for your question. And I think, Mark, you have a question that also relates. So do you want to unmute and pose your question as well?
Before I do, I must fully disclose, I was born in Women's College Hospital. So it worked. It worked.
Very nice.
Anyway, yes, my question was kind of effective questions when you're face to face with a doctor whose first reflex is to say, okay, we're just going to prescribe you this. It also begs the question around developing self-advocacy, and if that's not going to work for yourself, how do you form a self-advocacy team early in the game, right? People just don't do that. And then the second part of the question is, what role do you think social prescribing might be effective? Because most doctors I talk to don't even know what the hell the thing is. So there you go.
So great questions. That's interesting that people have said to me, especially people who, grew up in a different generation. So they're kind of in a generation where, you don't question the doctor, or you don't really feel that that's something you can do. And often people don't want to upset a relationship with their physician. But still, you need to be able to ask questions. So people have asked us, how do you ask the questions in a way that is helpful to everybody. And so that's where we came up with 3 questions that you can ask your physician when you want to have medications reviewed, or when a new drug is being considered. So the questions that we had that we felt were things that people felt comfortable asking was, you could ask your doctor, could an existing drug therapy be causing this new medical condition that I'm having? Could a lower dose be used or an alternative drug therapy be initiated? And then, is the drug needed at all? Or are there other sort of non-pharmacologic things that you could potentially do, like, for example, exercise or things like that, that might actually manage the problem? So we created questions that might help people with exactly the situation that you're talking about, so that they just feel comfortable asking the questions, and it generates a really good and positive discussion. So I think that maybe speaks about, it is important that people question things if they're not comfortable with it, or really understand if a new therapy is being started, why it's being started, because down the line there could be another issue coming forward, and so they need to understand that context. You've also raised something that's really important about this whole idea about social prescribing, and maybe people haven't necessarily heard about that. I think we started talking about it maybe just a couple of years ago, so it's kind of relatively new as a concept. But, for example, sometimes a person may be coming to their physician and really they're feeling isolated, or they're feeling lonely. And, maybe that's not making them feel great. And in some cases, people would say, well, is there a medication that could help with this? But maybe it's not a medication that they need. Maybe it's what they need is to be connected with a group where maybe there's an opportunity for more social connections, or, more kinds of engagement. And maybe that might address some of the issues or challenges that they're facing. And so that's where the idea of social prescribing comes, where a physician can actually write, some people actually do that, write a script to say, why don't you go and, connect with this organization? So, for example, there are a number of centers that are designed for older adults, where they have, regular get-togethers and social events, and people become part of a community and really get involved with these activities. And so that can be an example of a social prescribing. Or maybe it's about, there's a walking club that people might be interested in joining as a way to have physical activity as well as social engagement, but actually telling them where that group is, and helping them make the connection so that they can be part of that. But there's many different things in communities, and probably, in some community, it might be this group. In another community, it might be something else where things are happening in that particular setting that might be of interest. Thinking of programs that might be available, for example, in libraries that can be, of a lot of interest. So there could be a range of different things, but it gets people out of thinking that the only thing a physician prescribes are drug therapy. And we know that's not the case. They can prescribe a lot of different things, but these social elements are really so important. So I don't know if you've had experience with that kind of thing being helpful as well.
I think the problem is, to your point, not a lot is known about social prescribing so far, right? I mean, we need to educate on that, right?
Yes, I think it's something that it's important to raise awareness of. And as I say, it's also probably very community dependent as to where the resources might be in a particular community. So, to do it well, you need to kind of have connections, know what those resources are. But it is something that I think is catching on and, makes a lot of sense.
Yeah, thank you, Dr. Rochon. Yeah, I think, for myself, we had a session all about social prescribing. So if people are interested, we had, and that was very enlightening, I think, for me to learn about exactly how all of that works, because it is so new, but seems to be having quite a lot of benefit for individuals, but also for health systems and providers. So it's a very interesting kind of emerging topic, I think. I'm going to go to just another comment in the chat from Eileen, because Eileen says that polypharmacy issues is his top priority for pharmacists in Ireland. So I'm wondering, Dr. Rochon, what is the role of pharmacists here?
Well, it's interesting you say Ireland. One of our colleagues, Dennis O'Mani, has done some really fabulous work in Ireland. He created the stop-start criteria, which is one of the most widely used criteria in the world to help identify what is the right combinations of drug therapies for people to be on. But pharmacists play a really important role, and I think that role is, growing immensely over the last couple of years in helping to review medications. So, they are the people that are incredibly knowledgeable about medications. And in my own experience, I would often work really closely with a pharmacist. For example, when we were doing clinical work, looking after older people in a hospital type setting, the pharmacist would be right by your side because medication review is so important. And they would work to review the medications and help to identify what would be the plan. For example, if you were wanting to adjust medications or taper medications or start new medications and how you would go about that. And so they're a really, really important member of a team, for example, in acute care setting. Often in the primary care setting, when you're seeing your family physician, there can be a pharmacist who's part of the teams when people are working in the team setting. That's really important as well. And then there's pharmacists that are associated with, the various drugstores as well that also can do, for example, medication reviews. So they're a really valuable resource to do working directly with the physician or being able to look at the medications separately. So I'm really glad to hear that you're having a really good experience in Ireland. But just to reiterate that I think they play such an important role in how we optimize the way we prescribe medications for everyone.
Mm-hmm. Yeah, absolutely. I want to come back to maybe just some of the questions. I think what emerged from, Francis's question and Catherine's question is just the importance of caregivers and the role of kind of loved ones, and oftentimes in advocating for older adults in these scenarios. So do you have anything that is specific in terms of advice to caregivers in terms of how to best manage that? I mean, I think you mentioned how to have these conversations, which I think also applies to whether you're the individual or whether you're kind of the loved one. But is there any, nuance there that you've seen in clinical practice?
Well, caregivers play such an important role in obviously helping individuals, but especially related to their medications. I mean, it can be very, very stressful trying to make sure that somebody's taking the right medications and keeping on top of that. And I do think it's actually one of the reasons why people may need to go to more supervised care settings is because it can become too difficult for caregivers to manage the medications and too stressful. So it's really something that's important. When a person is going to see their primary care physician or going to have reviews done, I think it's really important that a caregiver is there if they're, somebody that is involved in that person's care, because you need another person there to be, as we've talked about, advocating, but also to describe what the scenario is, like what's actually happening, and to bring forward any particular concerns, because often the individual maybe doesn't necessarily feel comfortable doing it on their own or may not be able to do it on their own. And so it's really critical to have another person there with them. Sometimes it can be like a spouse, it can be a partner. But this is something, that not everyone is in that situation. So sometimes it can be a family member who often is stepping into that role, or sometimes it's even a neighbor. But it is important to have that voice there as well to help advocate for the individual.
Mm-hmm. Mm-hmm. Absolutely. I think, you know, is there any, just since we are kind of an international audience here at the Global Cafe, I'm wondering if there's any other kind of international kind of either best practice or you know, insights that you can share from how people are dealing with prescribing cascades from around the world. Is there any kind of innovation or anything that you're seeing in your work?
Well, there's a number of things that clinicians use to evaluate medications and to determine, to some extent, which ones are what we always call potentially inappropriate for the individual, because there's always circumstances that, you know, you may not fully understand where medications are needed, even though they may not be considered, you know, necessarily the ones that are the most appropriate, but they may actually be the best ones for that individual. But there are some international guidance pieces that clinicians can use. So I mentioned in Ireland, they have, there was the stop-start criteria. They're used all around the world, but it came from Ireland. And in the United States, there's a criteria called the Beers criteria that again provides sort of list of medications that are considered potentially inappropriate to help people sort of identify where they want to focus their attention. And something that we're working on, which is currently going through the review process, is we've created a list with an international group of experts of all of what we consider to be potentially inappropriate prescribing cascades. So I think I've told you that, you know, there's been hundreds, you know, written about and talked about around the world. But we brought together a group of international experts to think about what are the key ones that you should have top of mind that you ought to be thinking about in terms of thinking about, you know, prescribing cascades and that sequence of prescribing. And so we've created a list now of these drugs that people can have. And so that would potentially help clinicians, for example, to say, okay, you know, are any of the drug combinations that this person's coming in with, do they fit with any of these prescribing cascades? Or as another one of the people on the call mentioned earlier, you know, could there be a way to use this information at different levels? For example, could it be put into electronic systems so people could say, hey, this person's on this drug, I'm about to start this drug, you know, this could be a prescribing cascade. Let's ask a few more questions. So it could be something that could, I think, really help in terms of thinking about how do we do these things a little bit differently and better.
Mm-hmm. Yeah, absolutely. I think, you know, I wonder, because you kind of mentioned you know, maybe there's a flag in terms of medical records and things like that. You know, I wonder how, you know, how this plays in terms of when we think about the importance of integrated care in our health systems. And, you know, obviously, you know, I think our health systems at the moment for older people are not necessarily the most integrated in terms of, you know, the variety of different services that older people may need from a variety of different healthcare professionals. So, you know, do you see a relationship there in terms of, you know, moving towards a more integrated healthcare system and preventing prescribing cascades?
Well, I think maybe you could think about this in a variety of different ways. So if you think about, you know, we have primary care and we have acute care, and then there's a whole lot of care that's happening in the community. And so I think you need to think about what are the ways that maybe you recognize that people are going to be flowing through these different kinds of systems. And you want to make sure that this doesn't inadvertently, for example, lead to prescribing cascades, but also it could be opportunities to prevent prescribing cascades. So I think we've also mentioned that some of the times when maybe these prescribing cascades might occur might be when you have a different, it might be somebody who's not so familiar with the person who's involved in the care. So maybe it happens following an emergency room visit, or somebody's been in hospital, or they went to a different physician or something like that. And so you need to be able to find ways to share information so that everyone's kind of on the same page in terms of what's happening. Often that the family doctor has a big role to play there in terms of looking what's happening and bringing it all back together. But you could also imagine that if you have integrated care in the sense that you have access to different kinds of resources, you can work together. So we heard about social prescribing. So what are the ways that maybe rather than thinking about medications, you could think about an alternative approach that might, for example, help with engagement or might help with physical activity that may mean that you don't need certain medications. For example, if it was an arthritis piece, maybe physical therapy may be really helpful, or maybe occupational therapy or something like that. And as a result, you no longer need a medication. So you can work with the other resources that are out there in the community. So I think it has the opportunity to maybe make care better in a lot of ways and to prevent prescribing cascades. But also, when you have people moving through the system in different ways, we have to be alert to how this could potentially lead to things like prescribing cascades. And so I think we have to be particularly attuned, for example, in reevaluating medications if somebody has recently been in hospital or recently been to the emergency room or something like that, so that we make sure that everything is optimized.
Mm-hmm. Yeah, absolutely. I think that's a great kind of message as we move towards the end of our session. So we have a couple minutes left in today's session. So I'm just going to take a moment to introduce next week's Global Cafe. And Dr. Rochon will come back to you for some final takeaway messages. So speaking of integrated care, next week on the Global Cafe, we have Dr. Yuka Sumi, who's the medical officer of aging and health at the Department of Maternal, Newborn, Child, and Adolescent Health and Aging at the World Health Organization. And so some of you may be familiar with ICOPE, so the Integrated Care for Older People framework or handbook. And so they've just recently released the second edition of this handbook. And so our Global Cafe will be all about integrated care and the work that they've done on this framework. So we're very happy to be joined by WHO and Dr. Sumi next week for that session. All right, so I'm going to come back to you, Dr. Rochon, for any kind of key takeaway messages from our session today.
Well, I think the big one is just to think about this idea of prescribing cascades and, think about, the questions I think I've said that you might think about asking when you're getting your medications reviewed. Could an existing drug therapy be causing a new medical condition? Could a lower dose or an alternative therapy be started? And is the drug needed at all? Are really important questions that I think you could ask when you're meeting with your providers and reviewing your medications. And then we've also heard about sort of some of the frontline things that you might want to be thinking about doing. And I think it's helpful to keep a list of all of your medications and write down when, the date they were started, and who started them and why. Because as I say, you forget that information over time, and it can be really, really valuable to start seeing these patterns emerging. And then it is important to make sure that your medications are reviewed on a regular basis with your healthcare provider, just to make sure that you are on the right combination of things. And so I think those are a couple of practical things to think about. And then just having, as I've said, this idea of prescribing cascades in the back of your mind, just to see if there's patterns there that are things that ought to be explored. The whole idea, medications are so important for people, and we want to make sure that people are on the right combination for them.
Well, thank you so much, Dr. Rochon. We have kind of a number of people in the chat, and I'll echo that this was kind of very informative, particularly in a practical way for, for older people themselves or people who are caring for older people in terms of having these conversations and being aware of prescribing cascades. So I thank you so much for joining us for our Global Cafe, and thank you to everyone for posing your comments and for engaging with us. And we hope to see you all next week for another great session. So wishing you all a really great weekend.
you.